Thanks so much, Sue. Welcome, everyone. Thank you for joining us. We're really excited to teach you about what goes on with venous insufficiency and what we see as the vascular practice. So to be started, I'm going to talk about just the basics, how many people are affected in the US. It's a pretty common disease. Approximately 2.5 million people in the US are affected. Not everyone will go on to develop severe disease. However, 20% will develop ulcers and kind of complications from the disease. Most people do have common risk factors such as age that we see greater than 50 years old are more affected. And then over the age of 65, that's the age where you get increased risk of developing ulcers and complications. Females are more prone to venous insufficiency, including pregnancy, just because if you think about it, you're growing a baby, that's putting added pressure on the legs, making it more complicated. Along with that, weight also increases the risk of venous insufficiency. So we are seeing a trend where the increase in obesity in the United States are also increasing the risk of the venous insufficiency. Tobacco use and history of leg injury are also risk factors, as well as genetics. A lot of my patients do have a family history of varicose veins, and their family members have complications from venous insufficiency. So backstory with vascular, we see two types of blood vessels in the body. So break down, the arteries are what brings the blood flow from the heart to the feet. That's that pulsing sensation. So if you feel your heart rate, that's the artery. The veins' job is to bring that blood flow back from the feet up to the heart. Along with that, there's lymphatic vessels that wrap around the vessels to kind of pick up that extra fluid that they weren't able to bring back up. So looking closer at the veins, the arteries have a pulsing sensation. So that's that heart rate. They have a musculature inside the veins that are able to bring the blood flow naturally down to the feet. However, the veins don't have that capability, and they're having a difficult time bringing back up blood flow because of that pulseless sensation. So in order to do that, not only do they work with the muscles in the body, so the more that we walk, our muscles actually contract and squeeze that blood flow back up. But along with that, there's these little valves in the veins. So if you're looking at the photo, the valves are supposed to open, the blood flow goes up, and then the valves shut to prevent that backflow of blood. However, in venous insufficiency, those valves can get damaged or they get worn down over time. And that blood flow not only goes up, but it goes backwards, leading to heaviness, aching, and symptoms that I'll go into more in detail. So what signs and symptoms to look out for? So the signs that we look for are varicose veins. And I'll go into kind of the details about the different types of veins that we're looking at. But varicose veins, leg swelling, the skin almost gets this thickened, brawny appearance. And we also see a skin darkening of the lower leg. So what happens is when the veins are under so much pressure, red blood cells are actually starting to leak out of the veins, and that hemosiderin, which is a breakdown of the hemoglobin, actually stains the skin, leaving a brown discoloration. Along with that, over time, the risk increases the risk of ulcers. So the skin starts to be under so much pressure that the skin starts to break down and ulcers can form. A lot of times we see ulcers in the middle or the outer parts of the ankle. So that's what we're looking for. A lot of my patients come and say, hey, I feel like I'm walking through concrete towards the end of the day. They're dragging their legs, they're having pain, they're having a heaviness that they can't get rid of unless they're elevating the legs. A lot of symptoms that they also say are swelling, skin dryness, itching, and almost like a tingling sensation. Some patients develop a restless leg where they have the feeling of they always have to move. So what types of veins are we looking at? So there's three different types of veins that we're able to see as providers of vascular. So the first one is spider veins. Probably the most common vein. Doesn't necessarily mean that there's something else going on inside. These are a lot more cosmetic. A lot of people get them standing on their feet. Females are just more prone to them. And actually sun damage can also increase the risk of developing these. along with spider veins. Reticular veins are almost this bluish kind of vein underneath the skin. Both spider veins and reticular veins are cosmetic. There's nothing that we do that says we need to investigate this further. However, with varicose veins, that gives us an idea there might be something deeper going on where we should investigate and do a further workup. Varicose veins are often these big worm-like veins that can develop anywhere on the leg because of that venous congestion. So as providers, we kind of classify the different areas of vascular or venous disease. So on the left, you see a healthy leg. Most people do range about the C1 or C2 where they develop spider veins or varicose veins. And then our job is to determine, is this at risk of getting progressive where we see this swelling and this discoloration, and we want to prevent that as much as we can. The further venous disease progresses, you get ulcers, and then once the ulcer heals, you're still classified as a C5 going forward. So you have symptoms or you think you might have something going on. We usually work with our PCPs. There's a great deal of Baystate providers and even outside of Baystate that refer to us to further investigate and kind of determine, hey, are you a candidate versus let's do a further workup. You can also self-refer. We see a lot of self-referrals for spider veins or questions about any leg swelling. So when you come to us, we'll kind of explain what's going on. We'll do our physical exam. Expect to change into some lovely shorts because we do need to take a look at your legs to see what's going on. And when we come to us, we're doing our assessment. We're looking for all these background changes. Do you have spider veins? Do you have varicose veins? Any leg swelling? Or any discoloration or any history of ulcers. So a lot of patients are referred to us for leg swelling because there is an underlying cause of leg swelling that can be venous. Is it necessarily caused by venous? No. So actually there's over 200 different causes of leg swelling. So to kind of break that down, venous insufficiency is only one of 200 different causes. So that's our job, is to determine, is there multiple different factors? Is the veins being the primary source, or is there something else that's causing this leg swelling? So just to give you a background, there's a lot of different factors of leg swelling, and these are kind of the different breakdowns, whether it's one leg, both legs, and a lot of times we see patients with medications that are very common in practice that are increasing the risk of leg swelling. Two of those being amlodipine or calcium channel blockers used for high blood pressure, as well as gabapentin used for pain and neuropathy. So what do we do and what do we recommend for treatment when a person first comes into their visit? Compression stockings. So a lot of patients do not like to wear compression stockings. However, the goal of compression stockings is to give the leg a little extra hug to help the veins fight that gravity, to fight that pooling of the blood, to make it go back up where it should be. It also helps alleviate that pressure on the skin to prevent that thickening, that heaviness, and that aching that a lot of patients do complain of. So when you come to see us, Avery and I actually do our measurements of the ankle and the calf, and we provide you with those measurements. So we also give you the length just because not everyone is the same size. There is a prescription shrink compression stocking and there's lighter compression stockings. Based on what your symptoms are and what we feel is more comfortable, we want the best for our patients. So if we feel like you need a higher compression stocking, we would give you the higher prescription strength of compression. However, a lot of patients don't tolerate compression stockings, and we find that the compliance rates do drop because the compression stockings are very tight, they're uncomfortable, and a lot of people don't like them. So we do recommend, if you don't like them, there's also lighter compression strengths that we do recommend. The goal is just to kind of alleviate the pressure of those veins to decrease your symptoms. With compression stockings, I actually if you do have varicose veins on your thigh or around your knees, I actually recommend my patients wear bike shorts or knee sleeves, just because a lot of patients don't tolerate the thigh-high compression stockings. And the goal, like I said, is just to kind of help compress the legs a little bit to decompress that pressure along the veins to prevent those symptoms from worsening. So at our first visit, we kind of depend, do you need a further workup? A lot of times, if patients come in with spider veins, you don't actually need a further workup, or the reticular veins. It doesn't necessarily say, hey, there's something else going on. Like I said, those are more cosmetic, and we can treat them without an ultrasound. If you do have other symptoms such as heaviness, aching, some discoloration, or some varicose veins, we do recommend an ultrasound to further work up your symptoms and your signs to see if there is any insufficiency underlying that we may be able to treat. The ultrasound kind of guides our treatment options, and we have you follow up afterwards in 3 months, just because our credentialing body actually likes to see that you tried 3 months of compression, as well as insurance companies. So we do recommend you follow up in 3 months with the compression stocking use. That kind of leads into our next segue of treatment. So, no, I think that's it. All right, so I'm going to transition to Avery. So he'll kind of take over further.
Hi, everyone. I'm Dr. Ching. Before I continue on with treatment options, I don't know if you want to ask if there's any quick questions at all, Sue, or should I just continue on?
You can just continue. We can take questions at the end.
Okay, sounds good. So in terms of treatment options, the first one I put up here is medications, kind of keeping in line with sort of non-procedural, non-surgical options. Not heavily used in the US, I don't think, but there are some good studies out of Europe that do suggest that some herbal supplements, such as most commonly butcher's broom, is a common one. There's also something called, the actual extract is called like MPFF. I can't even remember what it stands for. Something like micro something flavonoid. Diazmin, Daphlon is also known as, because I can't really pronounce it. That's why I usually just recommend butcher's broom. I don't, again, the studies have different strengths and such, so there really isn't a particular strength or brand that we have that we recommend. It's something you'd have to take every day, but a lot of the colleagues that I've met at these conferences that have that are from Europe say that a lot of their chronic patients use these, and they swear by it. They say it does help. The thought process is that it does help strengthen those valves a little bit more, which Kristen was talking about. So for surgical treatment or procedural treatment for venous insufficiency, one of the approaches is an ablation procedure. Historically, people use lasers. Lasers are not used as much today. There's radio frequency, which basically works on the same principle of a laser, where you're basically burning the vein down. And then there's also glue, which works on the same principle as well, but instead of burning it down, you sort of clot it. You clot the whole vein down. It's a little bit of it doesn't kind of make sense, generally speaking. Why would I remove a vein? But the analogy I always use is that if you're working on a project with 10 people and one of the people in your project team is always late to the meetings, doesn't show up to the meetings, does the wrong assignments, sends the assignments in on time, and then you basically eliminate that person from the project, you drop from the group. Now you only have 9 people, but it's more effective because you don't have that one delinquent person. So just think of your vein as a problem vein, and eliminating it from your leg either through ablation, either through radio frequency or with glue. You're not going to compromise your overall circulation. You're essentially just eliminating the problem. And varicose veins can be treated in a couple of different ways as well. The varicose veins, we offer either staphylobectomy. So in the office, we numb up the leg. We do a tiny little incision that doesn't even get sutures, and we basically have a little hook, and we kind of pull the vein out and then tie it off. The goal with staph lobectomies in varicose vein treatment is essentially you have this network of varicose veins that are, under pressure, and you're just trying to break up that network per se. Varicose veins, the way I kind of think of it, I always use sort of a highway analogy. So if the larger veins inside your leg aren't working well and it's backing up with blood, as Kristen described, the varicose veins are sort of like the on-ramps onto that highway. And so if the main highway is backed up, then all the on-ramps to the highway will also back up. And that's why when we see big varicose veins in legs, it's essentially a manifestation of underlying venous insufficiency. So for those that are local, I always use the analogy of Route 5 during the Big E. It's the Big E in September. Route 5 is all backed up because everyone's trying to get there. And then all the ramps and off ramps that are trying to get onto Route 5 as well in West Springfield also start to back up. Sclerotherapy is another option as well. There's different types of sclerotherapy. Essentially, we use a really small needle and we use a solution. We use a solution called Sotradecol. Basically, it's an irritant that collapses the vein down and also clots it down. For the ablation procedure, what to expect? It's an office-based procedure, takes usually about 30 to 60 minutes. We typically will prescribe some Ativan the night before and the day of the procedure. It just helps kind of take the edge off for some people. So many patients just kind of sleep through the procedure, a little bit more drowsy, but it's not full-on anesthesia with a breathing tube or moderate sedation that you might get with a colonoscopy. There's local anesthesia, so typically you might get some cream and you wrap your leg in a sort of a plastic wrap. That kind of just numbs some of the needle sticks that you might get, as well as local anesthesia where the catheter goes in, which I'll show you in a second. And I try to make it a relaxing environment. Some people bring in ear pods and listen to a podcast. Other people listen to music. If you don't bring it, then I just throw on Spotify and, you get to select the music that you like to listen to. So, people seem to enjoy that. So the goal of the ablation procedure, again, is to alleviate the symptoms. And essentially the symptoms are impacting your quality of life. We talk about how the venous disease very rarely, if ever, I don't think I've ever seen it, would lead to amputation. When we're talking about amputations like the toe or the foot, that's typically going to be arterial disease, which is the blood flow into the leg. And this is the blood flow out of the leg. So if the goal is to improve your quality of life with the symptoms, we're looking to basically improve the symptoms which we think are a result of venous insufficiency. So that would be the leg heaviness that you might have, the leg swelling that you might have, the leg ache at the end of the day, and or also treating the varicose veins that you have. After the procedure, again, patients do very well with it when it's office-based. There is very little, if any, pain. Some patients talk about like a little tightness in their thigh, and that's after we glue the vein down or we burn the vein down. That vein kind of starts to scar in a little bit. So people talk about like a guitar string being plucked or like a rope that's kind of being tugged in the thigh. It doesn't hurt. It's kind of more of a unique sensation, and that typically will resolve after a few weeks. Some people with the glue, and whether or not it's the radiofrequency ablation or the glue is kind of insurance dependent. They both do an effective job. They're both equally, they both work the same. It's just a different way to skin a cat. With the glue, there is roughly a 5% allergic reaction. So again, we're clotting off the vein on purpose. When you clot off the vein, people can get inflammation. And sometimes that inflammation is very aggressive and causing a lot of redness and itchiness. Usually it's dealt pretty well with warm compresses and non-steroidals like Advil or Motrin. Very, very rarely, and haven't had to do it in a few years. People might need a steroid pack for a few days just to kind of really get that inflammation down. No activity restrictions. Again, I'm working on trying to change the protocol and the instructions you get from the nurses because I think it's a little outdated. I basically tell people no real restrictions. You know, most people take a few days off from work, depending on what your job is. But for the most part, you know, you want to be walking that same day. Activity and exercise is fine. If people want to go on the treadmill, if you get the staph lobectomy, is a little bit less activity, only because those incisions don't have sutures in them. I put little white band-aids on them, and they'll just basically self-heal on their own within 5 to 7 days. And because of those little incisions, no swimming or hot tubs or anything like that. But other than that, you know, people do pretty well, and you're not going to be laid up in bed or anything like that. Risks of the procedure, we mentioned a little bit of that inflammatory response in terms of the inflammation that you might get, the redness and the itching. One of the other more, I shouldn't say common, of the complications, a deep vein thrombosis is the most common, but it's also extremely uncommon. So I would say less than 1% of the patients have a deep vein. Essentially what's happening is you have the superficial vein that we're treating is going to join the deep vein. Again, using that analogy, highway analogy I was using before, superficial vein would be like Route 5 joining I-91, which is a deep vein. So when we talk about potential serious complications, a deep vein clot is one that might potentially break off and go to the lung, cause a lung clot. And so depending on where we put the catheter or how much glue we place, there is always the possibility of a deep vein clot. Again, it's less than 1% of the time. It's essentially the whole point. It's the main safety feature when I do the procedures, making sure that we're safe and that doesn't happen. If you were to have a deep vein clot, depending on the severity of it, more often than not, when we do see it, it's just a little bit, or the clot just seems to join right at that junction. We might do a 45-day course of blood thinners and then rescan. Sometimes we just don't do any blood thinners and just rescan it in a week. And by then, after a week, it resolves on its own. So even then, very rarely has it led to more significant complications. And the other risk of the procedure is it may not relieve the symptoms. That's part of the whole conversation when we talk about whether or not we want to do a procedure or not. We're pretty conservative in our practice in terms of who we recommend having the procedure. If some people are coming in with a lot of different aches and pains that don't seem to line up with a venous related problem, we may not necessarily make that recommendation. So if people have a lot of hip pain or shooting down the legs, which might be sciatica, we may not recommend venous insufficiency, an ablation procedure, because it's not really going to make a difference for those people. Before I go into that, also too, on the testing that Kristen mentioned, it's not just looking for blood clots, it's a little bit more detailed, so it takes a little bit longer. Basically, what the ultrasound tech's going to do, they're going to find those veins, and then they're going to squeeze your leg. And in real time, when she showed you that cartoon about blood flow coming back, if there is an issue with the blood flow in the veins, we can see the blood flow refluxing or going backwards. And how long those valves stay open kind of determines the severity of your venous disease if you have it. And that also goes into our criteria in terms of whether or not to recommend that procedure. It's not so much a yes, no test, like you have it, you don't have it. And if you have it, you automatically have that procedure recommended to you. Kristen and I sort of use a grading scale. And so if your veins are perfect and your valves are perfect, then you get an A. But we see a lot of in between. So anywhere from an A to an F. F would be, you know, all your veins are not working very well and a lot of the valves are damaged. A would be perfect, and there's a lot of in between. So if someone has sort of like an A- test and their symptoms are kind of vague or not really solid in relation to venous insufficiency, we would not make that recommendation for an ablation procedure. We would just say, you know, you probably should wear compression stockings or something like that. If someone comes in and they have like a D, so a lot of the valves in their legs are not working well, and they have leg heaviness and leg swelling, despite using compression stockings, then we would more than likely make that recommendation to have a procedure done. This is a video, gives you a rough idea of what an ablation procedure might be like.
Before performing endovenous thermal ablation, the skin and surrounding tissues are numbed. The proceduralist makes a small cut in the skin, into which he or she inserts a very thin tube called a catheter. The catheter is guided into the vein to be treated using ultrasound imaging. The proceduralist applies radiofrequency or laser energy to the enlarged vein through the catheter's tip. As the catheter is pulled out, the heat causes the vein to collapse and eventually heal shut. The blood will then reroute through other veins.
What that didn't show is that obviously it's very high temperature that's going through it. And so for the ablation procedure, typically,
Proceduralist applies.
we'll make additional needle sticks where we put in local anesthesia to protect the skin and to kind of compress the vein against the catheter. With the glue, you don't need to have that additional local anesthesia and fluid to protect the skin. So I prefer the glue because I don't have to do a bunch of extra needle sticks. But again, it kind of comes down to insurance. But I would say if your insurance didn't approve the glue and they approved radiofrequency, that's just as fine. I wouldn't be concerned. You're not getting a worse procedure, an outdated procedure. Again, it's just a different way to skin a cat. Varicose veins. We talked about a little bit about the staphylopectomies. The number of little stabs that we do varies depending on how bad your veins are. And so usually we categorize it as less than 10 to 20 or over 20. As you can see in this patient here, if we were to do staphylopectomies in the office, you'd probably be over 20. But again, I numb up the whole leg. So first you get a lidocaine cream and then you sort of wrap it around your leg. That numbs the whole skin. And then the day of, I also put all that numbing fluid along the veins as well, make little incisions, and patients do very well with it. You might feel some tugging and pulling, but you really won't have any pain. Foam sclerotherapy is another option. So for me, if the veins are as big as the ones in this picture, I typically have not done foam sclerotherapy anymore. What foam sclerotherapy is basically I use that solution and we mix it with air and we have a nice foam into it, and that foam basically fills in the vein and then the vein clots off. The reason I don't use it for bigger veins is Kristen and I have run into issues where people get a really bad inflammatory response. That vein hardens, which is what we want, but it hardens, gets firm, and it takes a lot longer for it to go away than patients would like. So because of the post-procedural discomfort, we've kind of shied away from foam sclerotherapy of the big superficial varicose veins. If it's a smaller varicose vein or a little bit more under the skin, those might be an option. Conservative measures, again, that's always the case. Compression stockings rule the day. We typically, as you mentioned, don't recommend thigh-high or pantyhose, and that's mostly from a compliance issue. I acknowledge that, for this patient here, where you can see his varicose veins are above the knee, a knee-high compression stocking doesn't really alleviate these symptoms. Having said that, most of the long-term complications that people can have with significant venous disease is going to be below the knee. So the skin discoloration and specifically the ulcerations are almost, actually, I don't think I've ever seen it above the knee. It's almost always below the knee. And that's what that's what the compression stockings are really trying to minimize and prevent. Here's a little cartoon on staphylopectomies. Again, not shown is a lot of local anesthesia right here. You have a little vein. I make a tiny little incision. I go in with a little hook, kind of go fishing, pull it up, and then tie it off. Afterwards, sometimes people may get a little bit of bruising. Obviously, there is a little bit of bleeding with this procedure. So you may get a little bit of bruising and that goes away. Sometimes patients also have a little bit of firmness, and that's because the residual vein that's left inside will clot off. Spider veins. So spider veins are not typically going to be covered by insurance. I think very rarely is it covered by insurance. And if there's a question about insurance, I can talk about it at the end. It's going to be considered cosmetic. There are patients that come in and say, I have these spider veins and they're very painful or they burn. And I don't say that they're wrong, but insurance just won't cover it. So if they want to be treated either for symptom based or for cosmetic reasons, we can treat them. It's a sclerotherapy injection, so again, a very tiny needle. Again, we use that solution and we'll dilute it down. And then basically in the office, Kristen and I will stick the tiny little vein, inject it, and in real time you can kind of see the vein fill, and then you get a little bit of redness. About 4 to 6 weeks, sometimes a little bit longer, 4 to 8 weeks for resolution. If you're doing it for cosmetic reasons, we usually will say, 50 to 75% reduction rate. So you're not going to get a perfect look, but oftentimes patients have, I think she showed it in the beginning, that really large cluster. We can get the overall appearance. So the bright purple aspect of it, that can be reduced, and the number of ones that are visible can be reduced by 50 to 75%. But I don't think it's not realistic, and I don't think you'll find a vascular surgeon that will guarantee, one, will guarantee it to you, and two, guarantee complete reduction. And varicose veins, I've had patients tell me, spider veins, sometimes it can be like weeding. You take care of a few, and then, years later, some other ones may pop up elsewhere. That's sort of the nature of it. In terms of cost, we're pretty inexpensive, I think, relative to other facilities. So we do it based on time. So it's about $200 for 15 minutes worth of work, and about $400 for 30 minutes. So it is self-pay. You do have to put a down deposit ahead of time because patients often no-show, and then we lose that slot. But we're also cognizant that it's your money. So, if there are any complications or dissatisfaction, we take that into account as well. Is that it?
Yeah.
Oh, and that's it. So if there's any questions for us.
There are questions, but I just want to say thank you to you both. Brilliant presentation, great info. So thank you so much for that. Let's see.
Oh, I see them here.
You see them?
Yeah. So in terms of what leg injuries contribute to the risk, I think, it's hard to say. I think usually it's going to be a more significant leg injury if someone was in a trauma with
Like a car accident.
like a car accident,
Like a fractured
and some of the
leg.
veins were torn or disrupted or tied off during the procedure or by the orthopedic surgeons, because it's basically shunting additional blood flow potentially to the vein that's not working well.
The thing with the car accidents is it may have the venous insufficiency where the vein is damaged. But if you are still having underlying musculoskeletal or the bone was injured, you might be more prone to like swelling or even pain, even if we do treat the vein. So we do take that into account whether or not it would benefit you. We don't want to work you up for an ablation procedure, have you do the ablation procedure, and then have you come back and say, you know what, I'm still having the same symptoms. That's why we really, like Avery said, we do really take into account what the ultrasound says, what your symptoms are, and kind of your history as well, because we don't want to work you up for a procedure just for you to say, I still feel the same.
The second question, how in the ablation has the vein removed or is it just shut off? Yeah, that's a great question, and it's very, even now I struggle with a great way to explain it. Fundamentally, the goal in treatment of venous insufficiency. So you get the ultrasound, it shows that so again, there's a deep vein system and a superficial vein system. Deep vein system is I-91, I-84. If it's not, the valves in those veins aren't working well, there isn't anything we can do. We don't eliminate those veins because you need that highway. And really just going forward, compression stockings are going to be the recommendation. It's when the superficial venous system, the great saphenous vein or the small saphenous vein, it's when those valves are not working well that we want to eliminate it as a problem. The way they historically used to eliminate it, and people still sort of use the terminology, is a stripping, right? They'll say, oh, I had my vein stripped 5 years ago, 10 years ago. No one really does vein stripping anymore. So last time I stripped a vein was a great saphenous vein, probably when I was an intern, so that was 2004. Nowadays, I would say almost every vein procedure is an ablation procedure. ablation will include both radiofrequency, laser, and glue. But they accomplish the same purpose, right? So a stripping is eliminating the vein out of your body, so it can't pool with blood. And ablation does the same thing. I think shut off is a good way. You basically shut the vein down so it can't pool with blood. You're just doing it internally rather than stripping it out. And I think that answered the other question.
Mhm.
I would say very, very, very rarely. I have done a few times. Vein stripping. I can't think of a situation.
What happens is, I think if there is some, everyone's anatomy is different, so we don't no longer like strip the vein, but in a situation where an ablation might not be beneficial because Avery might have a complication and the surgery might not be able to be completed in the office. We actually do a ligation procedure, which is a little bit different, but it is in the OR. So that's kind of our alternative, whether an ablation procedure, because the surgeons that I work with, we don't do the vein stripping anymore. But an ablation, like he said, is basically essentially the same thing, but without physically removing the vein.
Rhonda asked a very good question. We'll be concerned of not having it done. So again, we're pretty conservative. I think on the Instagram reel we talked about the importance of having a board certified vascular surgeon do the procedure. There's a lot of non-vascular surgeons that do ablations and treat venous disease. Obviously, I'm biased, but the reason I'm biased is because we're typically very conservative with who we think would benefit from it and who we recommend it to. Mostly because we want to actually have it make a difference. A lot of people might have a little bit of reflux disease, so again, you're maybe an A- or B+. But is it really going to be making your legs swelling better if you have heart failure? Probably not, right? Or did we stop the amlodipine first, or have you try the compression stockings first? So we're pretty conservative vascular surgery as a group. So a concern of not having it done, what I tell patients is that if you basically have a little bit of leg swelling, occasional leg heaviness, and we get the ultrasound and there is some venous reflux, let's say you're like a B, right? So a couple of the valves don't work. If your symptoms aren't that bad, I wouldn't recommend an ablation procedure. What I do say is that you may be a little bit more prone to leg swelling, leg heaviness. So it might be a little bit easier for you to have leg heaviness or leg swelling than someone else. So if you're on your feet a little bit longer, summertime is a big one with heat and humidity, a little bit salty food, your leg may swell a little bit more easily and a little bit more than someone else. Does it have long-term consequences if you don't have it treated? And this goes to Margaret Sullivan's question: does it cause DVT? That's people who are more aggressive. That's typically their argument to treat it. If you have really bad varicose veins and venous reflux, you can get superficial thrombophlebitis. So again, the varicose veins, the blood is not moving along and it's just pooling there. And when it pools, it'll eventually clot. And so that's when you can get superficial thrombophlebitis, which is the inflammation of that blood clot. The varicose veins clotting off, I've never heard of a situation where they will migrate and cause a lung clot. So it's typically more just, you treat it with warm compress and non-steroidals. Sometimes it's a little bit more significant and it's a longer segment that's clotted off. And that's a discussion we have with the patient about, do you want to do this procedure to prevent it from happening again? But in terms of life-threatening blood clot, it's pretty unheard of. Technically, you are at more risk of a deep vein clot, but I think most of those numbers are as a consequence of other factors as well, not just the veins.
It's one of those, what came first, the chicken or the egg? Because a lot of times DVTs are obviously found with symptoms. We don't treat it just because you do have reflux, given the risk of the DVT. But having a history of a DVT can increase your risk of reflux just because the valves do get damaged with a blood clot.
Amanda has a question about, it's STAB, STAB. Yeah. So when I dictate it, the auto dictation never picks up stabby either. So it's STAB. Lifestyle choices, a big thing that we see, again, salty foods, and weight is a big issue. Obesity is a big issue. To be frank, if people come in and they're, obese and they're complaining of leg swelling, it's not uncommon. We'll work them up, recommend compression stockings, and it's not uncommon for them to come back with that reflux study, ultrasound, and the veins are fine, right? And that's a pretty common feature, or the veins are pretty good, A minus. So those are probably the biggest ones.
I think immobility is a large one too, just because the dependent position that the legs are, gravity's also going to pull things down. To go off of what Avery said, I've actually had patients with reflux noted, and then they come back years later and they actually lost 75 pounds, and we do a repeat reflux study, and their reflux has actually improved. So it does go to show that weight does play an important factor. Like I mentioned earlier, exercise is a big one, just because the veins work with the muscle pump. So the calf is a big muscle that squeezes the blood flow back up to the leg in order to get to the heart. Elevation also allows gravity to do an assistive job in bringing that blood flow back to the heart. But I've had patients where they are active, and genetics just does play a large role in some of these patients' lives, where you can do everything you can, and there's obviously limited things that you can do with genetics. But you can also make a very large impact on how your quality of life is with exercise and elevation.
Margie Babbitt has a question too. She says that she has venous insufficiency. She's been using the leg machine every day, which I'm going to assume is maybe the pneumatic compression, and wrapping her legs with compression therapy. Lost some weight, legs felt better, but then took an antibiotic, and then the legs swelled up again. Do antibiotics affect venous insufficiency? Certainly, with amoxicillin specifically, I'm not sure about. But again, if you have venous insufficiency, you're depending on which veins are involved. As I said, you're just going to be a little bit more susceptible to leg swelling, whether that's a result of having surgery and getting a lot of fluids or blood during surgery, being sick, certain medications, antibiotics, the weather, again, heat and humidity. So it wouldn't surprise me. We didn't talk about lymphedema. So there's the arteries and the veins, and then there's lymphatics. So lymphatics are, microscopic vessels that drain additional fluid in your leg. And that's often a common co-diagnosis with venous insufficiency. You can have both. Lymphedema, typically, it presents pretty similarly, but there's some features of it which, kind of give us that diagnosis. It's a clinical diagnosis. There's no test for it. But there's no common test for it. You can always go online and people talk about these tests, but practically speaking, no one does it. There's also no surgery. So unfortunately, really, it's managing the swelling with compression therapy, pneumatic compression, or like these little air boots that squeeze the leg and massage. Oftentimes, people with lymphedema, they're more likely to get leg infections. So when people get cellulitis of their leg, to me, that typically suggests a lymphedema diagnosis, but it's essentially managed the same. Other than the ablation procedure, it's managed in terms of getting that swelling down. More often than not, it's the conversation. In the compression therapy, I think a lot of times it's one of those things where physicians just say, do it, but they don't follow up on it. And there can be a lot of impediments for people to wear compression stockings, whether it's you have arthritis in your hands, you can't bend over. There are other options than the tight sock. There's Velcro wraps. There's lighter compression socks that Kristen mentioned. There's also compression gloves that can kind of help you if you have arthritis with your hands. So we kind of help people kind of figure out what works best for them if we feel like they really need it.
Yeah, our job is to give the tools that you can use in the toolbox to help minimize your swelling. Avery actually does a good job where he says there's a swelling reduction and a swelling maintenance phase. So just because you have leg swelling doesn't mean that it's not able to be reduced, but you do have to do a good job wearing your compression stockings, elevating, exercising to reduce that swelling. But just because the swelling is reduced and you get the leg circumference down doesn't mean that you can kind of just stop wearing the compression stockings. It's about maintaining that swelling to help prevent those increased infection risk, the swelling to return, and kind of start that cycle all over again.
want to get this one.
So elevation, we say I usually say if you're sitting down watching TV, make sure your legs are up. We like to say not kind of on an ottoman. We want them at least hip level. Even higher would be better. If you are laying down, we say higher than your heart. That helps just with gravity and bring it back down. We don't recommend compression stockings at night because most people sleep in the laying down position. Gravity's doing its job. We do recommend compression stockings, put them on in the morning, take them off at night. When my patients first come in, I know compression stockings are very difficult to go from 0 to 100 wearing them. So I say start with 3 to 4 times a week. You can pick and choose, but obviously you're going to notice that improvement. I do encourage patients to wear them more often. Elevation, it's more so how often are your legs swelling. If you do notice your legs are swelling more so at night, when you do get home, make sure you're elevating. But depends on each individual. But I usually say if you are sitting down, if you work from home or if you're sitting at a desk, make sure you're getting up throughout the day. If you are sitting at night, elevate the legs as much as you can.
Hey, Shelly. Shelly's got a question. Are the compression socks you buy on Amazon as good as the ones you get from a medical store? That's a great question. So historically with compression stockings, your PCP might just write you a prescription and say, here's a compression stocking. Compression stockings have different strengths. So historically, the ones that were prescription were 20 to 30 millimeters of mercury pressure. That's considered the standard. That's pretty tight. The ones I have 20 to 30, and I have a pretty tough time myself getting them on, taking them off. Insurances have gone the way of not paying for those anymore. Even if you did pay, they're a copay, but let's say they did cover it, it'd be like $80 to $100 for one pair. Compression stockings will degrade over time. So, it's going to be a continual expense. Insurances now will really only pay for 30 to 40, and 30 to 40 is really very rarely do I recommend that, only when patients have horrible leg swelling and ulcers and things like that. Even then, it's really hard to put on. Usually, you're going to need a second pair of hands. So for those reasons, usually when you come to the office, Kristen and I have a sheet on compression socks. We'll measure you. Oftentimes, patients, because when you're not measured, they're either too long, too tight. There's also something called wide calf option. Sometimes people's calves are wider than their ankles. And so if you don't get a wide calf option, your calf is really going to be uncomfortable. And to answer your actual question, are the Amazon ones as good as the ones from medical store? So the medical store ones, usually those medical grade ones, a little bit more durable, a little bit better quality, I would say. So the two common brands would be Sigvaris, Sigvaris, and Jobst, Jobst. But those are expensive. So you can get them yourself without a prescription, but they're, anywhere from $75 to $90 for one pair. And again, if you're wearing it every day, it will wear out in 3 to 4 months. So knowing that most people can't tolerate a 20 to 30 millimeter of compression stocking, usually Kristen and I start people off on a 15 to 20, which is a little bit more like a tight tube sock. And that is the strength that you normally find on Amazon, or Bombas is another company that has compression socks. And with that, I think it's basically all the same. The only difference I'd make is so they can vary anywhere from $15 to $25 a pair, maybe a little bit more. Kind of depending on your level of venous disease, kind of dictates to us which kind of recommendation we typically make. At the end of the day, something is better than nothing. And so I buy a lot of them just to see which ones I like to recommend. I've worn Bombas before. They have 20 to 30, which are not 20 to 30. So you always have to kind of be aware of that as well. I've gotten, what else do I have? I have Darn Tough ones, which are like a wool sock. Those are like a 15 to 20.
There's Copperfit. There's a lot of different brands.
I'm using Sockwell's right now. I think it's called Sockwell. Sockwell, yeah. Sockwell. I have their 15 to 20s. I just got those because they're inexpensive and they have nice designs. But when that wears out, I'm probably going to look online to find some other brands or something like that. I do have Sigvaris 20 to 30. I'll be honest, I don't wear them because they're really hard to get on and take off. So I acknowledge it. You know, when patients say I can't tolerate it, I'm there with you. So, but average age at which patients present, change recent years, thoughts on what? I will say for the most part, if it's a male, typically the males that we see, correct me if you see differently, more often than not, it's like young men, 30 to 40, and they have varicose veins. Lots of times they're just there because their wife sent them there and they said, your veins look ugly, and they're just concerned, but they're essentially asymptomatic. So again, we have that conversation. Do we need to do something if you're not having symptoms? But for women, I think we see the whole gamut. We see anything from 30 to 70s to 80s.
Yeah.
And we see patients that have had it done before in the past, if they've had vein procedures done before in the past. So I haven't really seen a change in the demographic for either gender.
Yeah, I mean, women, it can affect any part of their age. I've had patients that, like, I've had them since I was a teenager. A lot of it plays into genetics, but a lot of patients, women specifically, come in kind of after they're done having those childbearing years, and they're like, okay, I'm done having kids. I've had these varicose veins since my babies. I want to do something about it. But we do see elderly patients as well, kind of in their 60s, 70s. I talked about earlier, the risks of it worsening kind of when you're over 50, and we see more ulcers present when they're 65 and up. But we do recommend, if you do see that brownie discoloration or that skin thickening, and we would recommend you come in just to get an evaluation to prevent those ulcers from forming before it's too late.
And the last comment is thank you for answering their questions. And it was a wonderful presentation, and I concur. You are both brilliant, and we're so grateful for your time and expertise. Thank you so much for kicking off our 2025 Heart and Vascular series. And we appreciate our audience for their great questions, and we appreciate the both of you. Have a great day.
Thank you.
Thank you.
It was a pleasure. Thank you.
Happy Heart Month.